later, weeks later. So again, space, staff, and stuff. And the disaster doesn't stop just in the hospital. We're going to have patients that come and are able to go home. People may have long-term health, physical problems. Obviously, this is going to be traumatic. There's concerns, and Dr. Miller presented data on post-traumatic stress disorder, anxiety, and depression stemming from the World Trade Center. And of course, so both physical and mental health problems will be in the community. So Dr. Miller also presented a iceberg today. Response, the small tip of the iceberg sticking out of the water, and then the recovery, the huge, much larger part of the iceberg. And so we're going to need help as a community. We're going to need to help ourselves with resiliency. Again, there's a big look at resiliency here. And so this is going to be a response that goes on for not only months, but years. And folks are going to go to rehab, right? Folks are going to need to get strong again if they've been poisoned and paralyzed with an organophosphate. People may have long-term issues. So it's a continuum of care from point of injury throughout the response to recovery, rehabilitation, and really resiliency and, recovery. Not only recovery, but everybody's going to learn a lot, both physically, mentally, and spiritually, and so helping others then after we've recovered, or helping others with lessons learned. Better data, better decisions. The whole DR2 program, better data, better decisions. And so we won't just be helping us within this community, but everybody nationwide and worldwide. That's why the national and international partners are here.
Fantastic. So I'm curious about data. So why is it, I think one thing that DR2 is really stressing is the need to collect data then after the fact. And maybe people are collecting data like right at the beginning and because it's part of the the general protocol, but continuing to collect data and making that data available, to understand what are the long-term effects in the community and things like that. Can you speak to kind of the importance of that and the importance of maybe then sharing that data with other people so other people can kind of learn from what you all learned?
So the question is, why is the data that'll be derived from these 4 days together with DR2, why is that important, and why would it be important in a real situation? Well, Dr. Miller presented data today from World Trade Center response. People will have long-term effects. For me as an emergency physician, a medical toxicologist, the medical director or medical consultant for the Bureau of Public Health Emergency Preparedness for the State Health Department, as the editor of the Advanced Hazmat Life Support Program, the data is incredibly important. And I'm going to address it more from the acute effect, but we need to know, number one, we're going to need environmental data. The initial data will be, where do we expect the plume to go? As a medical toxicologist, we always say the dose makes the poison. And so that environmental data is going to be incredibly important. We're going to need data on the triage category of patients. There's a primary triage that occurs in the field, the secondary triage at the hospital emergency department, usually the tertiary triage to get in the ICU, operating rooms, to get the ventilators, to get the ECMO that's in limited supply. And that triage, there are different triage methods, but the simplest categorizes patients into 4 categories. Immediate, those who need life-saving treatment immediately to make a big difference. Delayed, those who are still significantly affected, but their treatment can be delayed without changing their outcome. The M is for mild. It's never mild for the patient or their families. It's a term of art. And then expected, those who have such a severe injury or exposure. Those that have such a severe injury or exposure that without new resources, should we just take a break? Yeah. Yeah, and we can just start that one over again.
It's one of those things where I try to do it when we're breaking, but as soon as we start
I hate to feel I broke you.
I have this sort of lingering cough.
You should see a doctor about
I
that.
know. Maybe I'll talk to you after this.
I'll just start over again.
Yeah, that'd be great.
Yeah.
Okay. And you don't need to repeat the question. We got that. You can just start over.
Okay. So the question is, why is it important to gather data on disaster response? And I want to address that from my perspective as an emergency physician, a medical toxicologist, as the editor for the Advanced Hazmat Life Support Program, and as the medical director or medical consultant for the Bureau of Public Health Emergency Preparedness. And the reason is this. We're going to need immediate data in the response. What are the materials? And again, knowing that it's chlorine, we have an ABCDE approach to caring for patients: airway, breathing, circulation, disability, meaning nervous system, and then exposure with environmental control. Chlorine is going to cause airway and breathing problems immediately. It can cause some skin burns. Malathion is going to cause systemic poisoning with increased respiratory secretions, difficulty breathing, bronchospasms, so trying to breathe through smaller airways full of secretions, and also weakness. So we're going to need to know immediately, based on triage category, how many immediate patients do we have, those that need life-threatening care, and we can provide it and hopefully make a big difference. Those who are delayed, those who are still maybe significantly injured or ill, but with treatment can do well, but we need to treat the immediate patient first. Those with milder signs or symptoms who we'll care for, but we'll care for the immediates and delayeds. We'll start caring for everybody immediately, but again, we have to focus limited resources. And tragically, sometimes there may be expectant patients, those who maybe died instantly or in the blast or with extremely high concentrations of chlorine. And so we're going to need the data. We need to collect triage category, primary, secondary, tertiary in the field at the hospital emergency department, and those who need ICU care, those who need ventilators, those who need extracorporeal membrane oxygenation. We're going to need that because if we exceed those resources, we're going to have to get them from, with mutual agreements, have them brought in, shared among hospitals in town through the ChemPAC program for the antidotes, atropine, pralidoxime, and diazepam. Among the hospitals here, we have pre-hospital ChemPAC program. The State Health Department will coordinate that. And the Poison Center will also help coordinate antidote sharing. So absolutely incredibly important early on. Looking at pesticide, organophosphate poisoning, if you look at the world literature, what are the important outcomes? Number one, we want to know what kind of bolus people got with pralidoxime, the initial dosing, and then what kind of constant infusion rate. And again, based on looking at world literature, some studies say it's helpful, some studies say it's not, but those that show efficacy shows that it must be given quickly. Time is tissue. Dr. Cairns and Dr. Cobb always emphasize time is tissue. We in Advanced Hazmat Life Support emphasize, and as emergency physicians emphasize time is tissue, whether it's a stroke, whether it's a heart attack, whether it's a burn, whether it's a poisoning. And so those studies that show pralidoxime works, the patients on average, median time got it within 2 hours. So we've got to get it on board quickly, use a high bolus and a high constant infusion rate. Boluses, that is the initial dose, gets you where you want. Infusions keep you where you want, that sort of thing. So we're going to need to know who got it, who did well. Outcomes that we'll measure from that will be the amount of atropine that's used, because the antidote pralidoxime combines with the free organophosphate, malathion in this case, and it also regenerates the enzymes. So atropine sparing, we have limited antidotes, so we'd like to see, is there an atropine sparing effect with effective use of pralidoxime? We'd also like to know duration of ICU stay. We'd also like to know how many patients needed ventilators, their duration of treatment on the ventilator, those sort of things, and whether, mortality rates. Tragically, there may be some deaths, despite the best state-of-the-art medical care. How many needed extracorporeal membrane oxygenation? Is there a difference between